Good morning. Today we will have a word-round discussion on management of stoma, which may be either a permanent or a temporary stoma. We are giving a scenario of temporary stoma. So Dr. Milind Alokji is a third-year junior resident at MR Bangalore Hospital present, and Professor Shomita Chatterjee, Professor of Surgery at IPGM SSKM, will moderate the session today. So Milind, I request you to please share the screen and give the scenario and keep for.
Good morning, ma'am.
Good morning, Milind.
Let's just read the scenario once.
Yes, please.
A 58-year gentleman presented with proximal rectal mass for which he underwent low anterior resection. Primary anastomosis with loop ileostomy was done. Today is POD 3 and stoma bag contains 1.5 liters effluent. How will you manage this patient?
Fine. Milind, before we start off with the management of this patient, this is a scenario which you are aware of. Okay, so let's assume that you have come to the ward and you see this patient, but you're not aware of the background. Okay, so let's take it off from there and then we'll move on to the management. So you said that the patient, your history says that the patient went on low anterior resection, and on the bedside you see there is a patient who is IV is going on. There is a stoma bag which, as you said, contains 1.5 liter effluent. Now, by looking at this patient, how do you know? The only information you have is that he's had some sort of a rectal surgery. Okay,
Yes.
that's all you know. So how would you know? You said that this is an ileostomy, but how do you know that it is an ileostomy if you do not have prior information?
Ma'am, we would look for the position where the stoma is. An ileostomy is usually sited in the right iliac fossa. So a stoma that is there in the right iliac fossa would most probably be an ileostomy.
Okay, so but is it always 100% true that the ileostomy is in the, it is yes, usually in the right iliac fossa, okay, on the right side, but don't be dogmatic about it because depending on the intraoperative scenario, sometimes we may have to position it somewhere else as well. Similarly, for a colostomy, though it is usually on the left side, you might have to position it on the right side. So accepted that it is usually on the right side. So if there is a confusion and you have a stoma on the left side, is there any other feature which will tell you whether it is an ileostomy or a colostomy?
Ma'am, again, we would look for how the stoma has been made. Usually, an ileostomy would be a spouting stoma, whereas if it is a colostomy, it would be flush.
Okay, so why do we make an ileostomy a spouting stoma?
Because the effluent out of the ileostomy is a proximal. Basically it's less refined, so it is more toxic. It can cause more skin excoriation. So the spouting helps that.
Don't say toxic. It is
In the sense it's more it's more harmful for the skin. It can cause more skin excoriation if it comes in contact. So we prefer that the stoma is spouting, so that when the stoma bag is attached, the effluent directly goes into the stoma bag and does not harm the surrounding skin.
True. So the 2 points to be said. Number one, it is more liquid.
Liquid. Yes.
That is the main thing. Okay, so that is why we want the stoma to look like a tap, so that it flows directly into the bag without spilling. So it is number one, more liquid. I don't say toxic, it said that it is more irritant to the skin.
Irritant, yes.
That is the right term. More irritant to the skin. So we do not want it to spill onto the skin. Anything else in the bag which will tell you that this is an ileostomy? Patient is post-op day 3.
Ma'am, usually the content from a colostomy would be more foul smelling. It would be more solid, and the content from the ileostomy would be it would be more liquid and yes, ma'am.
And more liquid. Anything about the color? Will that give you a hint?
Yellowish, ma'am. Usually it's a yellowish colored liquid, ma'am.
That's why I said you said post-op day 3. So right at the beginning, it is more of the greenish color, the
Green, yes.
content, right? So, but as the patient starts taking diet, and because we do not have the information whether the patient has been started on diet or not, as the patient starts taking diet, then the color usually changes to sort of a brownish sort of a color. Okay, so that is when you might have a confusion about the ileostomy or a colostomy based on the color. But there again, the consistency will give you a clue. An ileostomy, even if brown, will be more liquid, more fluid, whereas a colostomy will be, the content will be more solid in nature. Fine. So we have 3 points in favor of an ileostomy. Number 1, the position is usually on the right side. The content is more fluid. The color is greenish to begin with and then converts to little brown when you start the patient on diet. And most importantly, it is the appearance of the stoma per se. So a spouting stoma goes more in favor of an ileostomy as opposed to a colostomy. Now, here you've said that this is a loop ileostomy was done. Okay. So how do you know by examining the patient at the bedside that there is a loop ileostomy?
Ma'am,
Clinical examination will help you think that this is probably a loop ileostomy.
ma'am, when we examine the patient, we see that while we examine the stoma, we see that the two loops, the proximal and the distal lumen can be felt. So, ma'am, that tells us that it is a loop ileostomy.
So there are 2 openings, that's what you're talking
Two
about.
openings, yes,
Right, 2 openings. But there is something more. Now suppose you have 2 distinct openings, meaning that there are 2 layers of intestinal wall in between. Will you call it a loop ileostomy or could it be a double barrel, 2 things coming out together through the same skin orifice?
That would be a double barrel ileostomy.
So just saying 2 orifices is not enough, The posterior wall should be intact. So you only have a rent in the anterior wall, and when you put your finger through it, you can direct your fingers on both sides, that is proximally and distally. That will tell you that it is a loop ileostomy. I suppose the same holds true for a colostomy as well, whether it is an end colostomy or a loop colostomy, right? Okay.
Yes,
now,
ma'am.
my next query would be that if it is you said it's a loop ileostomy, this is one way of classifying the stoma, that it is a loop stoma or an end stoma. Now, in colostomy patient, a loop ileostomy is usually a temporary stoma, right? You have something like a temporary and a permanent.
Permanent.
In which patient with an ileostomy can you say that, can you say for sure in an ileostomy whether it is permanent or temporary?
Ma'am, a patient who has undergone an abdominoperineal resection might have a end colostomy, end ileostomy.
No, abdominal APR.
Abdominoperineal, will you have an ileostomy or an
APR.
colostomy?
APR, you do ileostomy. Why? Whole colon is there, na?
APR usually the descending or the
Sorry, complete
sigmoid
proctocolectomy.
Okay, if you've done a complete proctocolectomy, is it mandatory that the anal opening will also not be there?
Ma'am, without an anastomosis, if we do it without an anastomosis, and in that case,
okay,
we usually have an end
so
ileostomy.
what is the way in which to identify in a patient clinically that it is an end stoma? When you're examining the patient clinically, I tell you, can you tell me whether it's an end stoma or not? So how can you say that it is an end stoma by clinically examining the patient?
Loop stoma, it says there are 2 openings.
Yes, sir.
And what is there in end stoma?
So there will be one opening.
So that's an end stoma. I said, how do you know that, yes, this is an end stoma, but this is a permanent stoma? What will you examine it know that this is a permanent stoma?
Here,
What will be there in the perineum?
so it will be a blind. On PR examination, it will be a blind.
No, you cannot do a PR. You cannot do a PR examination because there is no anal opening.
There is no reason.
So if to know that it is a permanent stoma, you have to check the perineum. Examine the perineum. If the anal opening is there, you cannot dogmatically say that it's a permanent stoma. That means if the anal opening is absent, as in an APR, as you correctly said, then you know that it is a permanent stoma. So examination of the perineum will give you a clear-cut answer that yes, this is a permanent stoma or a temporary stoma. So you classified it number 1 as ileostomy and colostomy. Number 2, you classified it as temporary or permanent. Number 3, you classified it as, now other than ileostomy and colostomy, any other stomas that you are aware of? These are the commonest ones in our general surgical practice that we get, but any other?
Ma'am, there can be urinary diversion also, ma'am.
Duodenal diversion, anything else?
Gastrostoma, ma'am.
Yes, we don't do it very commonly, but yes, we did have gastrostomies at one point.
Yes.
So if you go by the definition, you will see that you can have stoma starting from right from the pharynx right up to the end. So anywhere in the GI tract, so you can have a pharyngostomy, which you can often see in case of esophageal surgeries, esophagostomy, gastrostomy, duodenostomy, when we try to bail out a stump blowout, a jejunostomy, a feeding jejunostomy, that is also a stoma, ileostomy, colostomy. So you can have it all across the length of the GI tract, but definitely the ileostomy and the colostomy are the commonest. Can you have a non-GI stoma? A non-GI stoma. These are all related to the GI tract. So can you have a non-GI stoma?
Yes, ma'am. Stoma through the urinary bladder, ma'am.
Yes. So what is that called?
Urethrostoma.
No. Bladder. Suprapubic.
So SPCM, suprapubic.
Cystostomy or vesicostomy. Yeah. So you can have either a cystostomy or a vesicostomy. You can have ureterostomies where the ureter is taken out. Okay. So since we've come to that, you'll realize that a stoma is normally, we generally think it is related to the GI, but it can also be related to non-GI, like in the urinary. So having said that, can you now define the word stoma for me? If I say a patient has an abdominal stoma, how would you define?
Ma'am, stoma would be it would be a connection made from it would be a connection made from a hollow from a lumen or a hollow organ to the abdominal wall, anterior abdominal wall, to divert the contents towards the anterior abdominal wall that can be collected outside in a bag.
Excellent. You said most of it. The only thing that you have to add is that it's an artificial opening. It doesn't happen naturally, right? So it is an artificially or rather surgically created opening of the intestinal or the urinary tract to the abdominal wall. So number one, surgically created. Number two, connecting either intestinal, GI or the urinary tract to the abdominal wall to divert either the flatus or feces or the urinary content, as the case may be, and where it can be collected in an external appliance. Fine. So this is by definition a stoma. Now this patient is post-op day, suppose I'll put it back 2 days before, and it is post-op day 1. Sir has done the lower anterior dissection. You had assisted him, you did the ileostomy, and you come for rounds in the morning. Okay. Now what are the things you're going to look for in the stoma, and what are the things you're going to look for in the patient? So let's take the patient first.
Ma'am, we would first of all go with the complaints of the patient. We will look for general complaints and complaints related to the abdominal part of the operation. In general complaints, you would ask if the patient has any respiratory distress. We would look for if the patient is feeling febrile, or if, and in the abdominal part of the questioning, we would.
Why did you suddenly ask about respiratory distress?
Because post and after reversal of anesthesia and on day 1 or day 2, respiratory distress can be one of the general problems that the patient might present.
Here, this is a place where your answer will take you totally off track, because I'm tempted to take you into causes of respiratory distress in a post-op patient. So to keep it safer, say I will assess the patient holistically, look at his parameters, examine his chest to ensure that it is clear, see that whether we can start him on a spirometer. Now I'll come to the abdomen, examine the wound. I'm not taking off the dressing, it's just the next morning, just to see whether there is any soakage or not. And I expect that you must have put a stoma bag already in the evening rounds, previous evening round. And then I'm going to assess the stoma. This is a very holistic way of looking at the patient. Okay, I'm going to monitor the input and the output, and if a rheostome is in situ, I'll see what is coming out. Okay, so this is a very structured way of looking at it. Now let's say that the patient since yesterday evening till today morning has had an input of 800 ml. You see that there is about 300 ml urine in the bag, and the stoma is not yet moved per se, because it is post-op day 1, mind you. But there are some, bits of, air bubbles in the back. So what is your inference? Is it a normal picture that you're seeing as for post-op day 1, or are you expecting something different?
Ma'am, I would expect the urinary output to be a little more, but as far as the stoma is concerned, on day 1, if the stoma looks healthy, otherwise the color is
we haven't commented on the look of the stoma still. We just said there are some bits of air bubbles in the back.
Then I would not, I think this would be a normal post of day one picture, and I would still want to monitor the stoma before
So
doing anything.
talking about monitoring the stoma and the look of the stoma. Now let me put a scenario. You see that the stoma looks a little, puffy, edematous, okay? Like a cake rising in the oven, something of that sort. So what is your idea? What do you think is the problem?
I think that it's because of local edema that the mucosa has swollen up, and I would want to do something to reduce the edema of
Let's take it one at a time. You said it could be local edema due to some local problem. Okay, so what could be the local situation which might lead to an edematous stoma?
Ma'am, if the if there is if the stoma, if the neck of the stoma is, if the it's tight, ma'am, in the sense that
The skin opening is small,
skin opening is small, skin opening
or
is
the sheath is very tightly hugging onto the stoma. These are the two layers, right?
Yes.
And we are more concerned about which one, the skin or the sheath?
sheath, ma'am.
It's more the sheath. If the sheath is very, something like strangulating the stoma, the intestinal loop that is coming out. So yes, so it could be either a very tight sheath closure or even a skin closure tight. That could be the cause of edema. Any other cause of edema? Yes, these are the more common ones.
Volume status.
So if the excessive fluid, if excessive
Yes,
fluid
if
is
you've
being given,
gone overboard with your fluid, because
for
sometimes
resuscitation.
even intra the anesthetist, they get carried away with the fluid. So fluid overload can cause gut edema, and this is a visible part of the gut. In other patients, you would not know that there is gut edema. Now let's assume that you've got a very good anesthetist at the head end, and the fluid orders have been perfect, and you suspect that it could be either a tight skin or a tight sheath. So what would you do post-op day one? What are you going to do?
Ma'am, at that point in time, I would just, if it is edema, if this is just edema, I'd first like to apply a Gauge piece soaked in either D5 or some D5 or on the stoma head, and I would see if that edema can come down with those measures.
How will
And not,
D5 help? How will D5 help?
usually it's a more hypertonic.
D5 is
Is D5
isotonic.
hypertonic?
So, ma'am,
That's the
sorry,
point.
D25. It basically sucks
That's
out
the
the
point.
water.
No, D5 will not suck water.
See, you may say that it depends on the extent of the edema. If the edema is extensive, you have to intervene and do something. But otherwise, usually post-op day one, next day, morning round, you wait. You wait and see maybe till the afternoon, evening, whether the edema is progressing or not. Usually they tend to subside. Yes, if it is not subsiding, D5 is not an answer. If you're talking about a hypertonic thing,
Yes, ma'am.
you might put a Maxalf soaked gauze or something over the. But otherwise, immediately post-op day one, we do not intervene. If it is progressing beyond that, then we have to think of assessing, because I will not like to put my finger and assess the sheath on post-op day one. I might tear the stitches which I have put. So it is in be a wait and watch. Okay. I'll just twist the scenario. Morning you've come and the stoma looks a little dusky. It's not black, definitely not black, but you're not happy with, you want a nice pink color, and it's looking a little grayish pink. So what will be your inference? What could be the problem?
Ma'am, that could be because of early ischemia that is happening in the stoma if the blood supply is not proper to the stoma.
Blood supply is not proper. When do you expect that the blood supply is not proper?
Ma'am, again, when there is some kind of again, when the neck of the sheet is very tight, so it is pinching on the vascularity.
Okay.
And or ma'am, if because of some reason the momentum that is supplying this part of the ileum that we have taken is being
Momentum or
mesentery, ma'am, sorry,
mesentery.
mesentery
Yes.
that is supplying.
So what happens? You can have that, there has been too much of adventurous dissection, over dissection, handling. You've stripped the mesentery of the intestine that you have taken out as a stoma. So that can be one cause of a compromised vascularity. Or the stoma is under tension. If it is, sometimes we do get that we are not being able to mobilize one. So the stoma is under tension, the vessels get stretched out, less blood supply to the stoma, a bit of relative ischemia. Or it could be that, yes, you have not noticed it, but you have basically cut off the blood supply. So immediately it will not show, but subsequently it will show a little dusky change. Now, when will you be alarmed? Again, do you immediately jump in, or do you assess something about the stoma to decide whether I should intervene straight away or wait for some more hours?
Ma'am, I think on POD one, I would like to still wait for some more hours. And
Okay.
again, if the color is not up to what I would expect, but again, if that, like you mentioned, those bubbles are coming up, there is a little the stoma bag is a little there's air in it by the evening, then I would expect that if the stoma is looking to start that it might start functioning, then I would still want to continue looking conservatively, see how the stoma progresses.
Now, can you assess how much is the ischemia, rather how deep is the ischemia? Because suppose the ischemia is just the little bit of the mucosa and serosa, which is where you have fixed it. Okay, sometimes we get too adventurous with the fixing, too many sutures. That can also cause a relative blackening, gray, becoming a little gray. So, is there any way to assess that whether the duskiness is only in the part which is near the skin, or whether it has gone deep down to the fascia and beyond? Is there any way clinically that you can assess?
I'm not sure.
See, if you look at it, number one, you observe that it is dusky. You need to know that if it is only the part above the sheath, superficial to the sheath, and worst scenario that it becomes totally black and falls off, but the rest of it below the sheath is healthy, you may still not do anything. But if you know that the blackening or the duskiness has extended to below the sheath, you know you have to intervene and refashion the stoma. So the easy way of doing it is take a test tube. It's a transparent thing. Lubricate it nicely with a transparent jelly. Introduce it into the stoma. Okay? And you flash your torch through the test tube. So you will actually be seeing the length of the stoma, because the test tube is long and straight, right? So you will be able to appreciate where the sheath is. Is the blackening only in the upper part, or is the deeper part also dusky? So if you see that the deeper part is dusky, you know you might have to refashion the stoma. If not, you can again wait and watch. Okay? Okay. So rare cases you may find, there is some oozing from the stoma. Rare cases, I really haven't seen any, but sir might have. Rare cases you might see that the stoma is oozing and there is some amount of blood in the bag. It's not a torrential bleed. Okay, if it's a torrential bleed, you take the patient back to OT, but you have some mucosal oozing sort of a thing. What do you do?
Ma'am, again, I would like to just observe it for now and see if the bleeding subsides, but I would like to carefully observe this.
Any role for putting some local pressure for some time?
As simple as that, actually. Just apply a bit of pressure. Okay, if it is just, as I said, these are just fine oozing, so that might stop it. So just put a gauze piece, a wet gauze piece, and compress for some time. Usually they stop. Yes, if it is not, then you have to think of using some sort of energy source, but that is not really recommended because it might create a hole in the stoma. And if it is a torrential bleed, then there's definitely something wrong. You have to take the patient back to the OT and evaluate. Okay, so these are the common things. Common problems that we usually see in the post-op day one. There could be edema, there could be some amount of bleeding, or there could be a duskiness. These are the things that are of concern to us. Now, we said that we are going to examine the stoma locally and also take a holistic look of the patient. Okay, so
you can discuss this part also. So, as we are discussing the all problems, you find that stoma is not pouting. There is some problem in the creation.
Okay.
There is some retraction.
Yeah, I was coming to that. Yeah. Okay, so since sir has brought it up, sir said that the stoma has retracted, but post-op day one, we don't usually expect it unless it is a technical flaw.
Yeah.
Okay, but even in spite of a good stoma, sometimes down the line, even if not immediately, patient comes back and says that the stoma seems to have sunk. So retraction of stoma, what would you like to do? This is usually a delayed problem.
Ma'am, on the first post-op day, if the stoma
No,
looks
not first post-op day, if it has happened, it is a technical failure. Maybe we didn't fix it adequately. But let's say patient has come back to you after 3 months when he is on follow-up, and he says that the stoma seems to have sunk in. So what would you
try
do?
to check whether the stoma is still functioning or not.
Okay.
The most important thing, and accordingly, if he's coming after 3 months, also if there is any, if the plan is to reverse the stoma, then we look for a definitive option. We can then go for, instead of trying to refashion the stoma, we would go for a reversal rather than refashioning.
See, the point is, what was the stoma made for? Suppose it was this very patient where he had an LAR, the purpose was a diversion of or protection of the anastomosis. You might very well go in and reverse the stoma. Suppose the patient is on chemotherapy or as the adjuvant therapy, then you would like to hold on. So it is not a one-word answer. You have to customize your treatment depending on what the situation is. And let's say it's a permanent stoma in a patient of an APR. So
Yes,
there you have to take a decision, right? Again, the assessment is, has it sunk up to the sheath and stuck there, or is it, one end has gone down? Sometimes you have one end going in. If it is a colostomy and it has gone up to the sheath, you can maintain it there. But if it is an ileostomy, the whole purpose is that you make it look like a spout. If it's not looking like a spout, then you have to refashion it. And if there is one end which has gone in, there is always a chance that there may be spillage of the stomal content peritoneally, leading to delayed complications. So assess the patient depending on which stage of treatment the patient is. Number one, is the whole thing going down, or is it one end which is going down? Is it an ileostomy or a colostomy? And you have to customize your treatment depending on that. You also have sometimes situations where the patient says that the stool was coming out nicely, but last few 1 or 2 months the amount is coming down and the opening seems to have narrowed.
stenosis.
Stenosis. So if there is a stenosis, then what do you do?
Ma'am, in that case, we'll examine the stoma and see that if there is a actual stenosis, we would like to locally see if we can dilate that.
No, again, if it is a temporary versus permanent stoma, the attitude will be, the approach will be different.
Again, the same thing. If the time is over, if the need for a stoma is over, you can consider reverting the stoma. But yes, if it is a permanent stoma and you have to continue with it, then again, a refashioning may be needed. So the point to be emphasized on is there is no one correct answer. You have to optimize your treatment depending on the disease of the patient, the stage of treatment that he is in, whether it is an ileostomy or colostomy, and the local examination of the stoma. Any other complications that you are aware of? So these are all complications of a stoma. We are talking about hemorrhage, edema, ischemia, stenosis, retraction. Any other one of the delays?
Ma'am, fistulation, ma'am.
Fistulation. What do you understand by fistulation of a stoma?
Ma'am, since we've pulled the bowel loop to the anterior abdominal wall, the incoming and the outgoing loop might lead to a separate fistulation, ma'am. Especially if it is in a setting of an underlying disease.
So you are saying that the afferent and the efferent limbs of the stoma, they have a communication. Is that what you're saying?
No, ma'am. I'm saying like basically there is separate communication, or ma'am, rather after we've closed the stoma and put it back in, there is a after we've closed this, after the reversal, if there is a post-operative
that is a different scenario altogether. So we are saying the patient's stoma is in situ. When you're talking about fistulation, yes, the part of the gut adjacent to the stoma might fistulate, but yes, this is rare, but sometimes happens in advanced malignancies. Okay, anything else?
Skin irritation, ma'am, skin excoriation, and
We'll come to skincare. We'll come to skincare. I'm just talking about the stoma at the moment. Anything else? Any other complications? Somebody has mentioned in the chat box that there can be a parastomal hernia. Have you heard about a parastomal?
Yes, ma'am, parastomal hernia.
So what is a parastomal hernia?
Ma'am, parastomal hernia is if there is herniation from the orifice that we've created in the skin. If there is herniation of the adjacent bowel wall through this.
Usually there is no herniation from the skin, mind you. It is, see, we have fixed the gut in the sheath. another loop of gut tries to come in through the sheath and the stoma. So it is not outside the skin. You will see a bulge in the skin like you would see in any hernia. So you will see a bulge around the stoma. So a parastomal hernia has to be treated. Again, is it a temporary stoma? Is it a permanent stoma? If it is temporary, you can again judge whether I can revert it. Suppose it is a permanent stoma, an APR again for that matter. How would you like to manage the parastomal hernia?
Ma'am, I would like to take the patient for an operative intervention, and what we can do is we refashion the stoma, but this time we place a mesh in between and support the stoma with a mesh.
Okay. See, there are again two options. You can, number one, as you said, you can bring down the stoma, repair that defect that like you would repair an hernia, and take the stoma out from a different point. So repositioning of stoma and repair of the hernia. That is one option. The other option is we have often scenarios, bad scarred abdomens. It is maybe difficult, challenging to refashion the stoma. What you said is an option, that you put a mesh, you make a hole within the mesh, take the stoma out, and the rest of the mesh you flatten against the abdominal wall. That is definitely an option. But the challenges remain that if you're using a polypropylene mesh, that has a chance of, eroding into the gut. So you definitely have to use a composite mesh or something higher up. And again, the mesh itself should not strangulate your gut which is coming out. So it is not an easy surgery. The easier option is, repositioning it somewhere. And that is when, a colostomy might be on the right side of your abdomen. Okay, so this was that scenario. Have you heard about a prolapse of a stoma?
Yes, ma'am.
Yeah. So you had made, say, a 4 centimeter spouting, and the patient comes back to you in your OPD saying that there is a 15 centimeter loop of gut in the colostomy bag. What do you do?
Ma'am, this would again, we would look for what indication the stoma was
Yes,
done.
again, I will not go into the same thing. So it is the same decision algorithm, and you will either need a reversion or a refashioning of the stoma. You were talking about skin irritation. So see, till now we were discussing only on the stoma. Now, what are the local complications that might happen?
Ma'am, the most common would be skin irritation, ma'am. The contents that are coming out more common with the ileostomy. When they come in contact with the skin, they are irritant, and so they might cause skin excoriation.
Skin excoriation. But the point to be remembered is, yes, ileostomy is more damaging to the skin, the ileal content, but it is not zero for colostomy.
Yes,
so protection of the skin is the paramount importance when you're dealing with a stoma. Now, what can you do as a surgeon to prevent this?
Ma'am, starting from the operative time, as the ileostomy, first of all, has to be made properly. In case of an ileostomy, it has to be made spouting and properly fashioned. Secondly, from the very first post-op day, we must see that the stoma bag is placed properly. And
what
as
do you
soon
mean
as
by placed properly? You're correct. Stoma bag placed properly, you said. But what do you mean by placed properly?
Ma'am, in the sense that the orifice that we make in the stoma bag should fit in such a manner that less skin is exposed around the stoma.
So they say that about 1/8 of a centimeter. So you can understand how less that is. Okay. So only that much gap can be left. Otherwise, there should be no gap between the stoma and the opening in the stoma bag, because that surrounding skin might get. So 1/8 of a centimeter only, that means what? 1/8 of a centimeter is how much? 2 millimeter, 3 millimeter, something to that effect, only that much skin can get. So your stoma bag has to be fitted as early as possible. Okay, usually in the same evening round, we put the stoma bag, but do not wait for the stoma to overflow and burn the skin. It's something like a burn. Now, other than this irritation by the stomal content, is there anything which can also be an irritant? Sometimes the stoma bag itself, though they are trying to make it a very good quality, the constant pressure of the stomach. Sometimes working in a government hospital, we have to opt for, cheaper options of stoma bag. They may not be the best. The constant irritation by the rim of the stoma bag also causes. So it is not just burning from inside. You can have contact dermatitis there also. and leading to skin changes. So how would you advise your patient to take care of the area to avoid these complications?
Ma'am, first of all, educating the patient about these complications, local complications, is very important. Secondly, ma'am, we must teach the patient to how to fit the stoma bag, so that if they, for example, if the patient is not able to access the hospital again, at least they are able to do it properly at their home. Ma'am, otherwise, skin care, we have powders and ointments that come along with the stoma bag usually. So we must ensure that we give that to the patient, provide that to the patient while he is in the hospital, or he or she is in the hospital, and teach them how to use them while applying the stoma properly.
Okay, so
These are skin barrier creams. These are skin barrier creams.
Yes, sir. So stoma care actually doesn't begin after the stoma is formed. Stoma care begins even prior to, because your planning of your stoma site is of paramount importance. So as far as taking direct care is, number one, better fitting appliances. Clean the peristomal skin well and dry it before applying the bag. Very correctly, sir said that you can apply, you have these stoma adhesive creams and applications which will cause minimum skin reaction. And you might have to use antifungals also, because we often get contact dermatitis, fungal infection in the peristomal region. Having said that, we said that stoma care actually begins prior to formation of a stoma. So suppose it is an elective patient like this LAR, and you are planning that probably he might need a protective stoma. How will you prepare the patient and decide on the site of stoma preoperatively?
Ma'am, first of all, once the decision has been taken, we must explain the procedure, what a stoma is and why is it required in this case to the patient, so that the patient understands and knows beforehand that this kind of a procedure will be done, so that post-operative, when he or she wakes up, it doesn't come as a surprise.
Secondly, very, very important is counseling.
Yes, stoma counseling. Secondly, education. We must educate the patient about that the stoma, how the stoma functions, and that it will how it will be fashioned. It will not hamper with the normal activities, and that we would initially briefly educate the patient that how the stoma management would be done, where it would be positioned, and ma'am, thirdly, that we would preoperatively plan where we want to do the stoma. Like in this case, we would like to do the stoma in the right iliac fossa. We should mark the site preoperatively, so that it's important. It's easier for us for to get the stoma out if everything.
What is the ideal site, Mark?
So it is in the stoma triangle, sir, marked by the umbilicus, the pubic tubercle, and the anterior superior iliac spine.
We'll take it a little slow here. See, sir asked a very critical question, that what is the ideal site, and you mark the stoma triangle. Now, my stoma triangle, your stoma triangle, is it going to be the same? The landmarks may be the same, but are there any other features which you have to keep in consideration when you're making this?
Firstly, it should be adequately away from the main abdominal incision that we are making, so that there is no spillage of contents, and the bag and the dressing can be done properly and separately. Okay. Secondly, it should be away from skin creases. Okay. Thirdly, in case of an
what is the problem if it is near the skin creases?
Ma'am, the bag attachment of the bag would not be proper.
It's a very thin patient, very, very thin patient. What other problem what challenge might you face? Away from bony prominences.
Away from bony prominences.
Okay. Again, at the other extreme, very obese patient.
Ma'am, the stoma should be visible. So if the stoma might have to place the stoma a little higher up in case of an obese patient, so that the stoma site is visible to the patient.
Now, for the stoma site to be visible, and you're doing a preoperative marking, which position will you mark the patient in?
Supine and
supine you make it, and the patient, suppose assume it's me. Okay, supine you've made the marking, and I sit up. It goes
supine and sitting both.
In all three positions, patient should be made to stand, sit, and lie down. Okay. Because on standing, you may get a very optimal position. The moment he sits, particularly in obese patients, it tends to go below the tummy bulge. So your bag will be uncomfortable, it will come off. Secondly, you have to keep in mind the type of clothing that he uses. If it is a man, you must know that the trouser strap or the belt line, that should be away from the stoma. Otherwise, he will not be able to. So you have to again customize it depending on the type of clothing your patient wears. The main outline of the landmark of the stoma triangle is absolutely correct, but it has to be optimized depending on the build of the patient. Okay. Now, you had said very correctly that pre-operatively, he should be counseled, otherwise he'll wake up with a shock seeing a bag attached to his head. You also have to ensure that he has a proper support system, because colostomy management does not entirely depend on the patient. It's a big social headache. So you must ensure that patient has family members who will help him, change the bag, who will give him the moral support necessary. So pre-op counseling will require counseling not only of the patient, ensuring he has a proper social support, and also counseling the family members who will give him the necessary backup. So next will be marking the patient, marking in the standing, supine and sitting position, keeping in mind all the issues we had discussed. So again, it is a individualized approach. There is no one blanket statement for all patients as far as marking of stoma is concerned. Now, when you are doing the stoma, creating the stoma, as a surgeon, what are the points that you will keep in mind?
Ma'am, first of all, the opening that we make in the skin and the sheath should be adequate. So
What
that
is adequate? How much is
around
adequate?
2.5 centimeters.
Usually we put 2 fingers
Two
and
fingers,
we
yes.
stretch it if necessary. Okay, yeah.
2
Next.
to 2.5 centimeters, ma'am. Then secondly, in case of the loop, whatever loop that we are taking out, we must ensure that it is healthy. Ma'am, thirdly, in case of
Again, how do you know it is healthy? As a
Ma'am,
surgeon, what precautions? These are
ma'am,
the surgical
would look for
steps that you have to be careful about when creating a stoma.
ma'am, we look for the whether the bowl that we are using is viable or not. It should look
Okay, number
pink,
one,
healthy.
it should be a good viable loop of bowel. Number two,
Uh,
there should be a relaxed level of mesentery.
yes.
The stoma should not be under tension. The there should not be over dissection in that area.
Okay.
Because an ischemia may be manifest later on. Introp, sometimes we do not get that askiness. Okay, and it should be nice and lax. At the same time, there should not be a window between the loop of gut going up to the stoma and the abdominal wall. Sometimes you have an internal herniation in that area, another loop of gut. So you should see that it fits well into the wall without a gap at the back, fixed securely at the level of the sheath, everted adequately depending on whether it is a colostomy or an ileostomy. No adventurous dissection in the level of the mesentery so that the vascularity is not compromised. Okay. So have you heard of something called a continent and an incontinent stoma?
No, ma'am, I've not come across that.
Okay. Then again, while taking out the stoma, where do we take it out from in relation to the rectus abdominis?
Ma'am, we take through the rectus muscle, ma'am.
Through the rectus. So why are we taking it through the rectus abdominis? Why
Ma'am,
not beyond the rectus abdominis? I mean, surgical, it will be so much simpler, we don't have to split the muscle, we go beyond the muscle and take it out.
because the muscle itself provides a support to the stoma.
It does provide, but the main support is at the sheath level, mind you that. Okay, what else?
Can the contraction of rectus have some effect?
So when you're retracting the rectus is contracting, what happens? It has something like a pincing effect on the stoma. So it is some form of not a proper, like a sphincter action, but it is some form of continence. It gives some form of continence. Okay. So patients can train themselves that, by contracting the muscles, we can, if in a public place, we can control the amount of effluent that is coming out. And sometimes they train themselves to such a level that they can just put a tube through the stoma to make it relax and most of the content coming out. So that helps you in forming it. So when you bring it out partially through the rectus abdominis, some amount of continence you give to the patient. Okay. Now your patient is going home. Okay, your patient is going home. You have to teach him certain things other than changing the stoma bag, which will help him manage the stoma bag. Let's say it's a permanent stoma again, because these are the patients who really need this training. So what do you teach him?
Ma'am, first of all, other than changing the stoma bag, generally the cleaning, like emptying how to empty the stoma bag properly, how to maintain it. Secondly,
I'll just stop you for a moment. How much should the bag fill before you should empty it? Not more than 1/3 of the bag. Otherwise, the bag tends to come off. So tell them that you empty it as frequently as possible. Do not let it become heavy and the bag comes off. Bags are expensive, so you have to counsel the patient accordingly. Okay, carry on.
secondly, then we must also educate the patient to identify properly whether the stoma is healthy, at least to get an idea whether the stoma is healthy
When
and
to come
functioning.
back to you? When to come back to you if there is a
Yes,
problem?
ma'am.
Okay, fine. What else? Let's
Other
say
than that,
everything is going fine, but what does he have to do?
ma'am, maintain his or her nutrition properly.
Okay, I'll come to nutrition subsequently. See, you have to teach him something called a stomal irrigation. Okay? So let's say that he is a 40-year-old man who goes to an office every day. It is a social embarrassment and there is a problem also, sometimes whole day if the stool is coming out. So what you teach him is called stomal irrigation. What do? In the morning, you tell him that you insert a rice tube sort of a thing into the stoma. You teach him how to do it and attach a bottle of saline or even boiled and cool tap water.
Yeah, this is now available as a kit.
It is available.
This stoma irrigation is available as a kit.
Yeah.
We shall be sitting on the commode and then pass this tube through the opening and then run even the simple water.
Fluid is, yeah. So once that is done, what happens is, what is our system of defecation in you and me? What happens is there is a stretching capacity of the rectum and it usually fills up. We are not evacuating whole day. When it reaches an optimum level, we get those stretch receptors which give us a sensation of defecation and we pass. So you are trying to mimic that in these colostomy patients. So when you run around 500 ml of the fluid, what happens is the stomal area gets stretched. So what happens is they get that sensation of defecation. You tell them that you read your newspaper, have a cup of tea, do something, let the bottle run. Once that is done and they take the tube out, the most of the stomal content gets emptied. And
it empties the whole of the colon from ileocecal valve to the rest. Once you lavage, this fluid goes up to the cecum. And if a competent valve, it doesn't go beyond that. So it washes the whole of colon and empties the whole colon. So it takes time now for the colon to get filled up. So what happens is if the patient does it regularly every morning, during the rest of the day, even though it is not an incontinent thing, very little fecal matter comes out. Yeah. So he can, sometimes patients with training can even avoid a stoma bag later part, okay? But we tell them, yes, you keep your stoma bag just for safety so that there is no social embarrassment that you suddenly spill out. But if 90% of the contents are emptied first thing in the morning, the necessity of these embarrassments, the happening of these embarrassments become less and less. So if it is a permanent stoma, you tell them that in the morning when you're reading your newspaper, run the irrigation, wait for 10-15 minutes, take out the irrigant and take out the tube and let the whole thing be emptied out. So that way the necessity for, whole day little bit of fecal matter coming out one after the other, that can be minimized. Talking about nutrition, you said that there is some question in the chat box. Yeah. Someone is asking. The first thing was we talked about the stomal edema, and she asked what should be the ideal IV fluid in the post-op period, because most of these edema in the stoma occur because of faulty fluid management. Yes. So what should be the ideal fluid therapy in the post-op period who is having a stoma? That is very important. Yes. See, the ideal fluid therapy for a stoma is not very different from the ideal fluid therapy in any laparotomy patient for that matter. The point is that number one, there are two things to be remembered. What is the volume that you are going to give and what is the content that you are going to, what type of fluid are you going to give? Volume has to be calculated by the weight of the patient, and post-op day one you will go into less than the maintenance dose, because usually in there is always a volume positive balance, okay? Secondly,
So it will be different from patient to patient. Don't give a blanket 5-hourly fluid or 6-hourly fluid. Customize it according to the weight of your patient. Also be kept in mind that what are the losses that the patient is happening. If there is a Ryle's tube, how much is the patient losing through the Ryle's tube? If it is a drain, how much is the patient losing through the drain? This has to be kept in mind when you are prescribing the fluid. If the point why I was coming to nutrition is the ileostomy, the content is what? Ileal content. The ileal content is rich in what? Sodium and potassium.
Sodium and potassium.
You have to replace. You have to remember your maintenance fluid has to be given plus the amount that the patient is losing through the ileostomy. That has to be replaced by an equivalent amount of normal saline because that is constitutionally as close as possible to the ileostomy. So if the patient is having say 700 ml of ileostomy discharge, that means you will have to give the maintenance fluid and add the 700 ml. The same thing that we do with a high Ryle's tube content. As far as the composition of the fluid is concerned, remember it is not only sodium overloaded fluid. Sodium in the post-op period, there is sodium retention in the body. So if you give only normal saline and DNS, there is going to be a sodium overload, which is not desirable. At the same time, you have to give some calories, which will come in the form of 5% dextrose. So immediate post-op period, remember the sodium overload, so that has to be avoided. You will not add potassium on day one because potassium is to be added only after 48 hours. All releases a lot of potassium into the tissue. We are not adding any potassium. So restrict on sodium, no potassium till 48 hours. Give dextrose to give the calories. This is going to be the volume. Be very cautious. Don't go into a volume load mode. This is as far as
one should remember that most important electrolyte in the post-op is sodium, because a lot of people give a lot of normal saline in the post-op period, maybe 2 liters, 3 liters. So that causes the most harm. More sodium will cause extravasation of the electrolytes in the extravascular space and cause edema. So that is most important. One should balance the electrolyte being replaced. Don't give too much of sodium in the post-op period.
Yes. So the point is again.
Shamita ma'am, hello.
Yes.
It's Manju Banerjee.
Good morning, madam. Good morning.
Good morning, Shamita. I had a point.
Yes.
You were telling students about the advice when the patient is going home with a colostomy or ileostomy.
Yes.
Can you mention something about the food which he has to take?
Yes, ma'am. I'll come to that.
The oral food. Thank you.
Thank you, madam. Okay. So this fluid was while the patient is still admitted, but now as madam said, the patient is going home. Now ileostomy, the patient again has to be told that he loses a lot of electrolytes through his ileostomy content. But the reality is this loss, decreases with time because the tissue there becomes something like a colonization. It becomes like a colonic tissue. Yes, it compensates. Okay. So the electrolyte loss gradually decreases, but in the early period, he has to be told to take extra salt, take fruit juices, because this is going to supplement the losses that is occurring through the ileostomy. When it is a colostomy, he has to be told that you take a low roughage diet. If you take a very high roughage diet, there's going to be more bulky stool. So you take low roughage diet, take something like isabgol husk, which, sort of binder sort of an action. So it is formed stool. The irrigation that I talked about, mind you, that is only for colostomy. That is not for ileostomy. Don't mix it up, okay? The irrigation is only for colostomy. So if the patient has a colostomy, then you ask him to take a low roughage diet. Give him something like isabgol husks, which binds the stool, so that is a structured form stool at certain times of the day, accompanied by the colonic irritation. So when it is an ileostomy, increase water intake, take fruit juices, take additional salt in your diet. This is the basic thing, but the very crucial advice has to be the peristomal care, because that is what causes a lot of morbidity to the patient. When it comes to a colostomy, it is a low roughage diet and give something like a husk, which will bind the stool.
What about protein versus smell?
Protein versus?
Smell in the effluent, in the colostomy.
Yes, I don't remember the answer correctly, sir. If you can help me, there are some diets which minimize the smell. But if you can help me with the
answer. If you take more of protein,
Mm-hmm.
there is more digestive product of protein which can cause more smell. So one should be having an optimal amount of protein so that smell is lesser. If you take more protein, the end products of protein will cause more bad smell in the stool.
Okay, sir. You in fact have some very fancy stoma bags, but with not something we can advocate to our type of patients, is where they have some filters in the stoma bag which absorb some of it. But those are not for general use. They are very fancy things. Our patients will not be able to afford it. So we're talking about stoma bags. I mean, what are the different types of appliances that you get commonly for your patients?
Usually I know simple
No,
stoma.
divide the simple. Disposable bags, reusable bags. So disposable bags are for single use.
Single uses.
Reusable bags may be single bag system or it may be a two-piece system. So these are,
as I said, it could be a single use or a multiple use. Okay, multiple use, obviously you're not going to wash it and wear it back, but the point is in multiple use, you have 2-3 options. You have something called a two-piece bag where there is a flange, F-L-A-N-G, which is fitted onto the body, and there is a bag which is put over it. Okay. So when you have to empty your bag, you can just detach that bag portion, the flange remains on the body, and you wash it, dry it, and you can apply it back. Okay, you can keep 2 or 3 bags, so that you can intermittently change the bag while it is washing and drying, put another one on the flange. But the flange is constant. It stays about 2 to 3 weeks, then the adhesive power comes off and then you have to change the flange as well. We have a poor man's replicate of this where we get these Romson bags where it is basically a belt with a ring fitted over the stoma. It is good for colostomy because, but not so useful in ileostomy because we've seen patients saying that it seeps through the sides. So here also you get a belt with a ring which is fitted onto the abdominal wall and you get some 50 plastic bags in the box. So each time, you attach that plastic bag over the ring and when it is full, you can just dispose it. So this is a poor man's replicate. So you can have a single piece, you can have two-piece, that is a flange and a bag, and the Romsons is a modifications of the two-piece thing. The point to be remembered is that as you had discussed previously that when you cut the hole to fit the stoma bag, that cutting, the measurement has to be very accurate. With the stoma appliance, they usually have these markings, they have these cutouts in cardboard paper so that you can fit it over your stoma and see which is the correct fit, and you make the hole in the stoma bag accordingly so that there is no extra gap. That has to be kept. And also in the stoma set, you get these ointments which are basically skin protectors. If in a very poor setting like you and me, the type of patients we get, they cannot afford this, Xylodam ointment is a good option to apply around the stoma. Another very good poor man's option is aluminium paint. The ones we use, you get it at the hardware shops because it basically forms a coating over the skin so that even if there is a spillage, it does not directly come in contact with the skin. But this answer should come last because you will not get it in textbooks and your examiner might not agree with you. Okay. So is there any other option? Locally, sir, we have found this to be very useful. So you make a layer over, there's a paint, it's a thick paint, put it, apply it around the stoma, wait for 5 minutes for it to drain. It's something like the paint we use over our grills. Okay, so you let it dry and you fit the stoma bag over it. So that way the skin is also protected. But textbook wise, you will have those creams and pastes and things which protects the skin from the exfoliating changes.
Okay, this patient you have done a stoma. What was the idea behind creating a stoma?
What was the indication of a stoma in this?
Why did you create the stoma?
So this is basically it's a defunctioning stoma,
Yes.
so that the anastomosis that we have made distally it gets time to heal.
Does the stoma prevents leak?
No, sir. Stoma will not prevent the leak, but it will reduce the effects of a prospective leak.
So it is easier to manage even
leak.
if there is a leak. You put a drain, then it will be draining, and the stoma will act as a diversion so that the fecal content does not go there and cause more of effluent. So stoma cannot preventively, but if there is a leak at all, management become easier.
So it is basically a protection of the distal anastomosis. It is a protection of the distal anastomosis, and this is always a case of a temporary stoma, never a permanent stoma.
So 6 weeks down the line, he came, and how do you decide? Yes, his time has come to close the stoma. How do you assess the patient? Yes, I will close the stoma now.
So
what are the factors that you will keep in mind?
So we would like to see.
This is a malignant growth. You operated. 6 weeks down the line, he came back to you.
So if the patient is taking any other therapy, so if the patient has gone for chemotherapy and radiotherapy or radiation therapy, we will see whether that course has been completed and what is the outcome of that. Whether patient requires
6 weeks time, nothing will be completed. You see, 6 weeks, and there are two things. Either you make the patient wait till the therapy is over, or a lot of the people will be preferring that close it, then I'll go for the next mode of therapy. So if in the 6 weeks time we like to close, what are the things you should look for? Yes, surgical point of view, I can close.
So we have to examine the distal,
Patency.
segment, the colon. In this case, we will examine the rest of the colon. We would like to do do it either through a colonoscopy, or we would like to pass a dye through the.
Or do you do some imaging?
Ma'am, basically, we'll pass barium through the.
So it's called a cologram, distal
Cologram, yes.
or a distal ideogram,
Distal
depending
cologram, and
on
we'll check whether the patency of the distal segment is maintained or not.
You've done a low LAR. Your concern will be, has there been any narrowing at that region? If there is a narrowing and you revert the stoma, the patient might go into subacute obstruction once again. So you have to assess the distal patency. Number one, that there is no narrowing at the region of the anastomosis, and also there is no twisting. Because sometimes when you take out, the gut might get twisted. So that is one thing. And overall, again, take a very holistic look at the patient.
Yes.
Look at his general condition. He is a malignancy patient.
Anemia, nutrition.
Yes. So if these are not satisfied and you revert the stoma, you might have a leak again. So is there any time frame that we must close by this time? Is there any time frame?
Minimum, we should wait for I think 6 weeks, but maximum I'm not sure, ma'am.
See, there is again no textbook answer to this. There are two schools of thought. That means an early stoma closure versus a delayed stoma closure. Delayed can mean anything after 6 weeks. Okay. So like suppose the patient say you agree with your oncologist, you have a team meeting and you decide that let him finish his adjuvant therapy, then I will close the stoma. That is a delay. But suppose it was a road traffic accident with a blunt injury and the patient is otherwise well maintained and you've done a stoma because of the lacerated gut there, you can very well close it much earlier. So, so you can close as early as between 4 to 6 weeks, provided the patient's nutrition is maintained, his hemoglobin is good, albumin is good, and your distal cologram is satisfactory. So you can have an early versus a delayed closure, and that has to be, but an early closure is very much possible. So don't feel that no, I must wait for 3 months or 6 months.
Okay, madam, we have crossed the time.
Okay.
We've gone beyond. So we have discussed the most part. Someone is asking colonoscopy. Yes, if you are doing a closure after 6 weeks or delayed closure, one should do a colonoscopy to exclude recurrence of the growth. There may be recurrence at the site of the growth, or there may be more proximal recurrence or distal recurrence. So one should exclude by doing a colonoscopy also, in addition to the imaging. Because in imaging, it is difficult to find the local recurrence. Okay. Thank you. We have answered the chat box question also. Somebody asked whether you do irrigation in ileostomy. No, we don't do.
No.
Ileostomy cannot clear by doing irrigation. And we answered about the fluid part also. Okay. Thank you, madam. Thank you very much.
Thank you, sir. Thank you, Milind. Well
Thank
done.
you, ma'am.
Thank you so much.